Welcome to Herzmedizin.de. We're very happy to have you here, and maybe you could introduce yourself quickly to our audience. You're from Slovakia and you have a presentation here at the ESC Congress.
Yeah, so my name is Allan Böhm. I'm a physician, researcher, and also entrepreneur. I'm founder of medtech startup Seerlinq, and I will have several presentations related to our startup here. And thanks a lot for having me.
Where we're particularly interested in acute cardiac care. What do you see as the biggest challenge in ensuring that artificial intelligence tools are deployable?
So first of all, we physicians need trust, and I think the LLMs, the large language models, make great job in this regard. So we can trust ChatGPT, Grok more and more. We can rely more and more on their answer, not entirely, of course, but I mean we have better and better trust in these technologies, thanks to the really rapid advancement. And especially in medicine, the trust is also expressed if a solution has medical certification, the so-called CE marking. And unfortunately, this is still lacking in many wonderful technologies. So the most important thing, in my opinion, is if any researcher has a good idea to not only publish paper, but to either do it by themselves or to partner with someone, but to go as soon as possible for the medical certification, because only then these wonderful ideas and technologies could be implemented into clinical practice.
One of your presentations focuses on predicting heart failure or shock after myocardial infarction. How can AI-driven prediction models be integrated into current clinical workflows without overwhelming clinicians with additional complexity?
Yeah, so this is a very important question. Of course, we don't want to use technology that will increase our workload. So the AI applications and technologies need to be as simple as possible, but as Einstein would say, not simpler, of course. And ideally, if they are integrated into electronic health systems, this is quite difficult to achieve. So many times there are, for example, scoring systems that use an app, and if this is the case, it's very important to use very simple parameters, because if I want to predict, for example, development of cardiogenic shock in my myocardial infarction patient, I really need to make it quick. And if I need to input a whole variety of parameters, that will take me 5 minutes. So no one would use prediction score like this. So keep it simple.
Your study on non-invasive remote cardiac pressure monitoring shows promising preliminary results in preventing heart failure decompensation. What are the key challenges you see for integrating this technology into routine clinical practice?
Yeah, so that's what our startup Seerlinq is about. So I can say that we are the world's first certified medical device for non-invasive and remote home-based monitoring of left ventricle filling pressure, which is extremely useful for monitoring heart failure patients, because based on their increased filling pressure, we can predict decompensation, and we can also adjust therapy, especially diuretics, and prevent these decompensations. As I said in the beginning, usually the biggest challenge is the CE marking in these new technologies, and fortunately we were cleared at the beginning of this year. We obtained the CE marking MDR Class 2B, so the strictest medical certification for non-invasive device. So we are ready to be implemented into clinical practice, and actually we are already operating in Slovakia, where we are now monitoring more than 400 patients. With, I believe, very nice results that I will present also here. And we have now even more data from longer follow-up that show the benefit of this technology. And CE marking is not a challenge for us. So now we only need the interest of cardiologists and also the interest of the patients. So I would say these are the biggest challenges. And actually, we are starting, to operate also in Germany. Hopefully, we'll make it already this year. So that's my ask for my plea to all the cardiologists. Telemedicine is recommended by the guidelines, especially hemodynamic guided telemonitoring. So it is really something that help your patients. So please pay attention to these new technologies and also motivate your patients in using them, because it's not enough if only the cardiologist is motivated. Also the patients need to be motivated, and they of course need to build a trust into these new technologies.
And maybe one last question. You just mentioned you just need to get the interest of the patients. How do you aim to do that? How do you talk to patients about those new technologies?
So this is of course a complex question. So one important thing here is that this can be done only by the physician, by the cardiologist, because we are overwhelmed by other, let's say, more complex and more sophisticated clinical work than explaining something into detail to the patients. So additional staff is needed. In our case, we have a strong technical support team. So if cardiologist recommends to patient our technology, he just needs to say to the patient that I believe it's good for you, and that's enough. And then the patient has a call with our tech support team, and they explain everything into great detail, because many times patients will be willing to use the technology, but if the cardiologist is only, 1 minute to explain very superficially what is it about, it's difficult to win the trust of the patient. But if there is enough time and if the patient understands it, then he'll be willing to use it. So it's important to have enough time for explanation, and this needs to be done not by the cardiologist, by the physicians, nor by the nurses, but by specifically dedicated people. And the good thing is, in our case, that we can provide these people. And then, of course, the patient needs to have positive experience. So, so this means if the patient needs to see that this solution works, and fortunately, in our case, the patient know that many times they got a call when we see that their filling pressure go up. Many times they see that there is the requirement to change the therapy, and they also see that suddenly they don't get hospitalized. So that's the second thing. They also need to see that the solution really works.
Professor Böhm, that's all very interesting stuff. Thank you very much for summarizing it for us, and we wish you a nice Congress here in Madrid. Thank you.
Thanks a lot.